So good evening, my dear doctors. So today's topic is actually cardiac cycle as well as Wiggers diagram. So this topic is very important for your MBBS Prof exam as well as for Viva YC because a lot of questions are from the concept which are based on the cardiac cycle. And believe me, if you are very serious about this cycle, hardly it will take 15 minutes to understand the basics of cardiac cycle. And once you understand this topic, cardiac cycle, you will be able to understand Wiggers diagram, pressure volume loop curve, and lots of MCQs in your exams are also based on this topic, cardiac cycle. Is this clear? So I will not going to give a lot of details which are not needed. I will concentrate on the concept which are must for your exam, which are the buzz point. If you remember those buzz point, you can write in your examination. So number one, what is cardiac cycle? So as we know, one systole plus one diastole. Very simple. It is called as one cardiac cycle. And what is the duration of cardiac cycle? So usually we say 0.8 second like this. But do you think it is a fixed duration or it keeps on changing? It is not a fixed duration. It is only when you are considering heart rate to be 72 per minute. Only then it will be 0.8 second. Okay. Otherwise, it is not going to be fixed. So 0.8 second is the duration if your heart rate is 72 per minute. Suppose if your heart rate is 100 per minute. If heart rate is 100 per minute, what will be the duration? Now it is 0.6 second. If heart rate is suppose 200 per minute, tachycardia. See, normal it is 60 to 100. What is the normal heart rate? 60 to 100 per minute. I'm just assuming that you are doing exercise or whatever may be the reason. If heart rate is 200 per minute, duration will be only 0.3 second. Very less duration. That is why there is a tachycardia. So duration will be very less. So systole will decrease as well as diastole will decrease, but diastole is going to decrease a lot. Why I'm telling you this? The basic fundamental of doing stress ECG. Nowadays we are doing stress ECG. It is also called as TMT, treadmill test. Nowadays we are doing stress ECG to confirm about the angina, MI and all. So what is the basic physiology behind stress ECG or TMT test? Whenever someone is running on the treadmill, what is going to increase? The heart rate. So whenever heart rate is more, automatically systole duration and diastole both will decrease. Now during systole, your heart is supplying blood to the systemic circulation. It is going to supply to the systemic circulation. And what about during diastole? During diastole, heart is giving blood to himself, coronary circulation. Coronary circulation. And if someone is having hampered blood supply to the coronary circulation and someone is doing treadmill test or is running or doing exercise, automatically the blood will be further reduced and he will suffer. He will start having some pain. So there is a hidden MI over there. There is a hidden angina that can be seen in the stress ECG or we can say TMT test. Sometimes in the exam nowadays they're asking physiological basis. What is the physiological basis of FRC? What is the physiological basis of stress ECG? Like that, they're asking multiple types of question. Even in the MCQ, they can ask. So this is the basic understanding of cardiac cycle and the duration. Now to understand cardiac cycle, why we usually forget about the cardiac cycle? Because we forget about the pressure. And I'm telling you once for all, if you understand the pressure change, you are never going to forget about the cardiac cycle. It is as easy as that. It's very easy if you understand the basic pressures. What are the basic pressures in the cardiac chamber? Okay, I will give a normal range. For example, in the atria, it is around 0 to 5 mm of Hg. In the left ventricle, it is 0 to 80 mm of Hg. Okay, and then it will go up to 120, 0 to 120. In the aorta, minimum is not 0 because it is an elastic vessel. Minimum is 80 to 120 mm of Hg. Why? Because this time in the NEET PG, they asked the same question. Okay, if you remember the Marfan syndrome. So I'm telling you, even if you're preparing for NEET PG from your first year onward, it is good because concepts will not change. And I always keep on saying that physiology, pharmacology, pathology, and medicine, they are like four pillars. If you have grip of these concepts, okay, you can solve more than 70% of question based on the concept. Okay, so don't forget in the atria 0 to 3 or 0 to 5 mm of Hg. In the ventricle, it is 0 to 120. In the aorta, it is 80 to 120 mm of Hg. Now, the valve which is between atria and ventricle is called as AV valve. Okay, and this is called as aortic or pulmonary valve. I will use the word aortic because I'm talking about the left side of the ventricle. Same cycle will continue on the right side. Same cycle. Okay, it is not going to change. So whatever phases we are going to discuss, okay, pressure will be different. But similarly, things can go on the right side. Okay, so let me start with the cycle. Okay, the first phase I always start from atrial contraction. But before atrial contraction, it is a cycle. It is a cycle now. So what happened just before that atrial contraction? So even before atrial contraction, your ventricles are having how much amount of blood? Even before atria is not yet contracted. When atria will contract, pressure will become from 0 to 5 mm Hg. Minimum is 0, maximum is 5. But even before atrial contraction, even before contraction of the atrium, ventricles are filled with how much percentage of blood? How much ventricles are already having blood? Answer is 70%. Okay, I will come to this phase at the end. So just before the atrial contraction, there is a filling of the ventricle. I will discuss later on, and that filling is called as passive passive ventricular. That is called as passive ventricular filling. So the amount of blood which is coming passively, not due to atrial contraction, passively from atria to ventricle is how much? 70%. And when atria contracts from 0 mmHg to 5 mmHg, this 30% blood will come. So rest 30% blood will be due to atrial contraction. Okay, so I started from atrial contraction. So when atria will contract, now ventricles are 100% filled with the blood. Clear? 70% from the passive filling and 30% from the active. It is active. It's active atrial contraction. 30% is from active atrial contraction. Okay. Now, I'll ask you simple question. When atria are contracting, is there any heart sound over there? Do you think there is a heart sound when atria are contracting? Yes or no? Just tell me. S1, S2, S3 or S4. Which heart sound you can get when atria are contracting? S1, S2, S3 or S4. You can comment on the live chat also, because if you interact, you will learn. What do you think? When atria are contracting, there will be S1, S2, S3 or S4, and never bother about that you are wrong or right. I mean, you are wrong, your answer is wrong, or you are correct in the, I mean, this class, because if you're wrong, you will learn and you will never make that mistake in your exam. Okay, I'll tell you, whenever atria is contracting, Okay, there is normally no sound, but only if atria is contracting against ventricular, against rigid ventricular wall. Only if wall is rigid, only if wall is rigid, only then there can be hard sound called as not S1, not S2, not S3, S4. So I hope from now onward till your medical career, I mean throughout your life, you are not going to forget about S4. S4 is a sound which is produced by atrial contraction when atria is contracting against rigid ventricular wall. Clear? Okay. So now atria is contracting and ventricle is 100% full. 70% from the previous passive filling and 30% from the atrial contraction. Now your ventricles are completely full. Now your ventricles are completely full, 100%. Okay. Now the minimum pressure of the ventricle is 0 and maximum was how much? 120. And minimum pressure of aorta is how much? 80 and maximum was 120. It means from 0 mm Hg up to 80 mm of Hg, because after 80 aortic valve will open. So from 0 mm Hg up to 80 mm of Hg, ventricles are going to contract in a closed chamber. So ventricles will contract in a closed chamber. So ventricles are going to contract in a closed chamber. That is why, doctors, it is called as isovolumetric contraction. So when ventricles are contracting from 0 mm of Hg up to 80 mm of Hg, ventricles will contract in a closed chamber, and as ventricles start contracting, AV valve will close. And when AV valve will close, it will produce which heart sound? S1. S1. So from now onward, never forget that S1 is always followed by isovolumetric contraction. S1 is always followed by isovolumetric contraction. Is this clear, doctor? From 0 mmHg to 80 mmHg, ventricles are contracting in a closed chamber. So now ventricles will contract and S1 is there. So S1 is always followed by isovolumetric contraction from 0 to 80. Now as pressure become more than 80 mm of Hg, what is the minimum pressure in the aorta? It is 80. Maximum is 120. So up to 80, aortic valve are closed. So 0 to 80, ventricles are contracting in a closed chamber. But as pressure become more than 80 mm of Hg, what will happen? Aortic valve will open. And as aortic valve will open, rapid gush of blood will come from ventricle to the aorta. Rapid gush of blood will come from ventricle to the aorta, and that is called as rapid ventricular ejection. From where? From 80 mmHg up to 120. I'm telling you, if you remember the pressures, the pressure change, you are not going to forget. Only when we are studying cardiac cycle without understanding the pressure change, only then we are going to forget about this. Otherwise, we will remember. So try to remember cardiac cycle with the pressure change. Now, from 80 to 120 mm of Hg, ventricles are contracting with the aorta open. Now, ventricles will relax from 120 mm Hg to 80 mm Hg. Now, ventricles are going to relax now. So, ventricles are relaxing, but aortic wall are open. So, what do you think? Ventricles are relaxing, but aortic wall are open. So, blood will move or not? Yes, blood will move. Rapidly or slowly? Slowly. So, that is called as from 120 to 80 mm of Hg, blood flow is slow. It is called as slow ventricular ejection, and this flow of the blood is only due to the momentum. It is due to the momentum of blood. What is the main cause of blood flow in slow ventricular ejection? Although ventricles are relaxing, sometimes you can ask me, sir, ventricles are relaxing, but why will blood will flow? Because aortic valves are open and already blood was rushing from the ventricle to the aorta. So it keeps on moving to the aorta due to, what is the answer? Momentum of the blood. Okay, and as pressure become less than 80 mmHg, okay, from 120 to 80, slow ventricular ejection. But as pressure become less than 80 mm of Hg, aortic valve is going to completely close and producing the heart sound called as S2 heart sound. Okay, S2 heart sound. So S1 was before IVC. Never forget S1 was before IVC. S4 was due to atrial contraction, and now coming to the S2. S2 is due to pressure drop from 120 to 80. So as it became 80 mm of Hg, automatically it is going to close. Clear? Now from 80 mm of Hg till 5 mm of Hg, ventricles are relaxing in a closed chamber. You can see here, ventricles will relax from closed chamber. Let's try to imagine. Now ventricles are relaxing in a closed chamber. So that is now, it can be called as isovolumetric relaxation. It is preceded by S2. So never forget that S1 is followed by IVC and S2 is followed by IVR. So S1 IVC, S2 IVR. Clear? Now, when pressure drop less than 5 mmHg, I told you everything can be discussed in 15 minutes. This is it. I'm telling you, for your exam, for your viva. Okay, these are the concepts which keep you help in, even if they ask you about the essay question, even then you can write following these points. Now, when pressure below 5 mmHg, what happen? AV valve will open and rapid gush of blood will happen from atria to ventricle, and this is 70% of blood. Is it active or passive? It is passive. It is a passive filling. It is a passive. It is a passive filling of the ventricle. That was atrial contraction was active, but this is passive. Now tell me one thing. When there is a passive filling of the ventricle, normally there is no sound. But can there be any sound if there is hyperdynamic circulation? Can there be any sound during hyperdynamic circulation? Yes, there can be a sound that is called as S3. That is called as S3. So during the discussion of cardiac cycle, we have covered the pressure difference, we have covered the pressure change, as well as all heart sound. S4 was due to atrial contraction. S1 was preceding IVC. S2 was preceding IVR. So like that, we have covered almost every heart sound with the cardiac cycle. See, so now your ventricles are having 70% of blood. So again, starting with the atrial contraction, 70% of blood was already there due to passive filling, 30% due to atrial contraction, producing which heart sound? S4. So this is the basic of mechanical activity of heart. If we study heart in detail, one chapter is electrical activity of heart, where we discuss about the SA node, AV node, pacemaker potential. Other chapter is mechanical activity of heart. So this is it for mechanical activity. After that, there will be a slow ventricular filling called as diastasis. Now, through this cycle, we can understand a simple Wiggers diagram. It is a simple form of Wiggers diagram, which you should not forget in your exam. Only if you understand cardiac cycle through pressure difference change, only then you can understand the Wiggers diagram. So this is your 0 mmHg, 80 mmHg, 120 mm of Hg. From 0 to 80 mm of Hg, Just now we discussed your ventricles were contracting in a closed chamber. So that is called as isovolumetric contraction. So from 0 mmHg to 80 mmHg, ventricles are contracting in a closed chamber. So it is called as isovolumetric contraction. From 80 mm of Hg up to 120 mm of Hg. As pressure become more than 80 mmHg, aortic valve will open. Rapid gush of blood will happen from ventricle to the aorta. It is called as rapid ventricular ejection. See, only with that concept you can label all the diagram of the Wiggers diagram. Now, from 120 mm of Hg up to 80 mm of Hg, ventricles are relaxing. Ventricles are relaxing, but blood is flowing slowly, and it is called as slow ventricular ejection. From 80 mm of Hg to 5 mm of Hg, ventricles will relax in a closed chamber, and it is called as isovolumetric relaxation. Very simple to understand. But I'm telling again and again, this can only be understood if you know about the pressure difference. Definitely, they will ask you either about the cardiac cycle, all about the Wiggers diagram, all about the heart sound. So only this half an hour of lecture is going to help you with all types of questions, either essay or physiological basis or even MCQ. Okay, so one thing I told you about S1, S2. S1 is preceding what? IVC or IVR? If you remember IVC. So S1 is always before IVC and S2 is always before IVR. That's it. It is called a simple Wiggers diagram. So first will be isovolumetric contraction, rapid ventricular ejection, slow ventricular ejection, isovolumetric relaxation, and then after less than 5, it becomes rapid ventricular filling. So this is about cardiac cycle and very basic about the Wiggers diagram. Now already we discussed about the heart sound, but sometimes in the exam they ask you the total difference. Tell me all the factors. This is important for your clinical viva also, clinical practical also, and theory also. So to remember about the S1 and S2, there is a mnemonic. In S1, there is L, L, and L. L, L, and L. Long duration, low frequency, and loud. It is long duration, low frequency. Frequency is low. It is around 25 to 45. And S2, remember like that. S, S, and S. That was long duration. It is short duration. Short duration. That was low frequency. This is sharp frequency. That was less than 50. It is more than 50. S1 is loud, L, L, and L, high amplitude. And S2 will be soft. MCQ can be asked. They can ask the difference between S1 and S2. So all these things can be understood if you remember the simple mnemonic. L, L, and L is S1. Long duration, low frequency, and loud. S2 is short duration, sharp frequency, and soft. And already you know S1 is start of IVC, S2 is start of IVR. S1 is due to closure of AV valve, S2 is due to closure of aortic valve. Now about S3 and S4. Again we know S3 is due to passive filling. Only when passive filling is having, hyperdynamic circulation. So during passive filling, during 70% filling of the ventricle, and if it is hyperdynamic circulation, only then we can get S3 heart sound like in children, in anemia, pregnancy, athlete, CHF. So in all those conditions, whenever you are going to get hyperdynamic circulation, it can be physiological, it can be pathological, but the main crux is here you will be having hyperdynamic circulation. In S4, I told you in the beginning of cardiac cycle, it should echo in your mind. Beginning of cardiac cycle was what? Atrial contraction. So it is active ventricular filling. How much? Only 30%. It is again inaudible, both are normally inaudible. Only if atria is contracting against rigid ventricular wall, we can get S4 heart sound. Normally, it is not found only when ventricular walls are rigid, like in the old age, acute MI. Acute MI. So this is about cardiac cycle, Wiggers diagram, and hearts. Okay. So this is it for today. Next Tuesday again, I will come with some other important topic for your exam. Till then, bye bye. Thanks.